Good morning, good afternoon, and good evening. I'm Mukta Sandhu, Senior Scientific Education Manager at Geislich Pharma, Switzerland. I extend a warm and gracious welcome to each of you for this World Webinar Tour. Today, we are privileged to host a distinguished speaker, Dr. Schwartz-Arad, who is renowned for her outstanding contribution in the field of bone augmentation, procedure for dental implants, and various other maxillofacial surgeries. Dr. Schwartz-Arad is specialist in oral and maxillofacial surgery, and she holds a PhD degree in cancer research, anatomy, and embryology. She was a senior lecturer in the Department of Oral and Maxillofacial Surgery at Tel Aviv University till 2008. In 2016, Dr. Schwartz-Arad is a research professor of the Pharmacological Research in Dentistry Group at the Faculty of Dentistry, State University of Granada, Spain. She's also a visiting professor at the University of Murcia, Spain. Dr. Schwartz-Arad is an author of more than 100 research papers, and she has written several chapters in several published books. Today, we will be learning from her about the posterior mandibular atrophy and bone augmentation with the help of biomaterials. So, welcome, Dr. Schwartz-Arad, and the stage is yours.
Good day, everybody. I'm glad you joined me. The topic of my lecture today is posterior mandibular atrophy, bone augmentation procedure with Geistlich biomaterial, BioOS, BioGuide in combination with PRP, bone marrow aspirating concentrated, BMA, and PPP, platelets per plasma. I'm an oral and maxillofacial surgeon in Tel Aviv. I work in my private surgical center. In this lecture, I would like to go over a few surgical treatment modalities to overcome the huge challenge of severe atrophy of the posterior mandible atrophy. When we look at the PubMed, at the posterior mandibular atrophy, severe atrophy for dental implants, one can see the amount of research performed in the last few years. This means that we don't have yet the best solution. So I will present today 3 surgical techniques to overcome this severe atrophy of the posterior mandible. So the first will be guided bone regeneration. What I would like you to concentrate not on simple guided bone regeneration, but on cases that we have infection. One would be chronic infection, and the other very challenging case of acute infection. And I have quite experience with this technique, and also we conducted the research, which I will give you some of the results from this research on the use of BIOS, BioGuide, PRP, and PPP in cases of guided bone regeneration at infected sites. The second technique, surgical technique, is autologous horizontal and vertical onlay bone grafting for implants placement in the posterior atrophied edentulous mandible. I have experienced these techniques for more than 20 years, and I would like to share with you this experience that I have in this vertical and horizontal onlay bone graft using autologous bone graft from neighboring area from the mandibular ramus. And the last techniques that I would like to present is mandibular nerve lateralization and transposition, simultaneously with implants placement. I would like to present this article that was published in 2015 on the bone replacement material and techniques used for achieving vertical alveolar bone augmentation. So this is very important, although it's not a new article, but still, we would like to find out what are the techniques and what material we can best use in severe atrophy for vertical augmentation. And let's go again, before we go to this article, to the literature. and find out about vertical alveolar bone augmentation. Since we are talking on severe atrophy of posterior mandible, most of the time we need vertical augmentation due to the position of the canal and the loss of bone, alveolar bone. So if you look here, again, most of the articles were written in the last few years, and you can see here the growing interest during the last few years on vertical bone augmentation. And we can see here we'll go augmentation, bone with ring augmentation, and several others that you can go in the PubMed and look for the solutions that you can find in the literature to overcome this challenging problem of vertical augmentation in the posterior mandible. So let's go back to this article. So we have 4 techniques that are possible for bone augmentation. The first is interpositional bone graft. We call it also inlay bone graft. The second mentioned technique is destruction osteogenesis. The third is onlay bone grafting and guided bone regeneration. I'm not talking about materials now, I'm talking about techniques. For instance, interpositional bone graft or inlay bone graft, you can put in the inlay autologous bone or xenograft or allograft. Yet, in both techniques, the destruction osteogenesis and interpositional bone graft, you need at least 5 to 6 millimeters of bone superior to the canal to be able to transfer this destructed part of bone superiorly. So in cases of severe atrophy, extreme bone atrophy, those 2 techniques are not reliable, and they can cause loss of the destructed bone or fracture of the basal bone. So we are left mostly with 2 techniques, either onlay bone grafting, again, I'm not talking about materials, just techniques, and guided bone regeneration. In both techniques, and this is extremely important to my opinion, is we preserve the original bone. We don't interfere with the original bone. So if we fail with the technique, we back to 0 and not to minus. So this is important to preserve the original bone at the recipient site. So I would like to present the first case of guided bone regeneration and ridge preservation. This case was referred to me after the loss of actually those 3 implants due to peri-implantitis, and all the 3 implants need to be extracted. And here you can see at time of operation the extraction of the implants. Just with ratchet it was easy to remove. It was disintegrated, and after disinfection with chlorhexidine and water peroxidate, this is augmentation with bios saturated with PRP, covered with PPP and collagen membrane, the BioGuide. So this is an easy, everyday, simple bone preservation that we can perform at time of implants placement, implants extraction, or even after teeth extraction. So nowadays, I never extract teeth or implants without performing some kind of bone preservation. So this you can earn 2 things, 2 important things. First, the volume, because one of the problems is to lose the volume at the area where you intend to place implants. So volume is very important, both the soft tissue and the hard tissue. Second, with time, I do it for more than 10 years now, with time we found out that we can actually get bone regeneration even at area of infections. So it's like socket preservation. So everybody do socket preservation. I don't like so much the name socket preservation. I prefer ridge preservation. Nevertheless, you can perform ridge preservation in very large areas, not only in sockets. This is 6 months after operation, and now implants can be placed. Of course, we can perform more augmentation at time of implants placement if needed. And here are the digital planning of the 3 implants. And now implants are placed. According to this planning, I take a sample, bone sample, at the area of bone preservation that was done with BIOS, PRP covered with BioGuide and PPP. Implants are placed and also healing abutments. Here is a part of the panoramic view taken immediately after operation. And 6 months later, rehabilitation was performed by one of the prosthodontists. Sometimes we can perform the same augmentation procedure in much large infections. And this is a very special case, which I've done, guided bone regeneration at time of implants removal in acute infection. Usually what we have is chronic infection, periimplantitis or teeth that are having periodontal problems, etc. Let's have a look in this case. What I have done actually here is not only the ridge preservation, later on I performed autologous bone graft and mandibular nerve lateralization with simultaneous implants placement. So let's see the different stages. This is the intraoral view at time of administration. So not much can be seen here except of some problem here in the lower jaw. Nevertheless, if we look at the panoramic view, this is a real disaster, real disaster. There are 5 implants and the infection is all over, almost breaking the thin jaw. Look at the huge prosthetics, that bridge that was built on top of it. So they took it to extreme. They fixed prosthesis on 5 implants, and this did not work. If you look at the CT of 2 of the implants here at the area of the first premolar, or the 44 and 34 on the other side, both sides, look at the CT slice and look at the amount of infection and loss of bone around these implants. And the same is for the rest of the implants. Only 1 implant here actually holding still the entire huge prosthetic work. If you look at this picture, well, I don't usually recommend to perform augmentation at acute infection. First, you need to treat with antibiotics, and then at the end of the procedure, at the end of the acute phase, then you can go for the operation. Nevertheless, I would like to show you this case, which I have decided to perform everything under 1 general anesthesia. Because a lady needed general anesthesia for this treatment, I have decided to perform the augmentation as well. So this is the time of operation. Extracting those implants were not the hard part, as you can see, covered with infection and pus. And then a small flap was raised just to clean the area very thoroughly, and then augmentation is performed with BIOS, BioGuide, and PRP, saturated PRP, covered with PPP, as you can see here, and suture with 4-0 nylon suture. This was just like emergency care. And this was quite brave to perform this augmentation and not wait a while after curating the entire infection. But I was worried to lose all this volume of tissues if I wait like a month or 2 after extraction the failed implants. So this is already 3 weeks later, at time of suture removal. One can see here the huge amount of bone needed to replace the infection, and one can see here the healing of the submental area. These scars are old scars, nothing to do with the treatment we performed. 6 months later, we can see that the bone was incorporated. Well, we don't know if it's a bone yet. That's why I take bone samples each time I perform implants. We can see radio-opacity at the area where there was radiolucency before. But let's see what were the other steps that I perform to place implants. One has to bear in mind that if you have a patient that already have implants failure, it might happen again. So I don't want to make any compromission in the treatment, and I would like to perform more augmentation to get in a better condition prior to implants placement. So 6 months later, we harvest bone marrow from the posterior iliac crest, and then you can see here the cleaning of the implants that I decided to leave to hold the denture, temporary denture. Sample were taken from area of augmentation, and this is the bone grafting harvested from the posterior side of each side of the mandible for vertical augmentation at the area of the loss of bone in the anterior area of the mandible. 1.5 diameter self-tapped titanium screw were placed, fixed the two monoblock, and I use a lot of bios saturated this time with bone marrow covered with PPP to close the gap between the two blocks and the recipient site. And then I wait another 6 months. This is already 1 year after the implants removal. So we can see here the screws, fixation screws, and the implants that I left that helps to hold the provisional temporary denture. Let's examine the CT of that area. So we can see the screws here on the left side and on the right side, and see the amount of bone that we get at the area where we lost the implant. And you remember the huge radiolucency that we had around the failed implants. Now it's all new bone formation. There was no bone there. We just have a surrounding of a little bit of buccal bone. So now implants can be placed. So at that time, I decided to perform a lateralization of the mandibular canal. So planning the implants with surgical template. And this is a window for the lateralization of the canal on the left side, carefully dissecting the canal with a piezo device. And then you can see here the bundle, very careful dissection, and then placing implants according to the pre-planned surgical template that we planned. Very careful not to damage the canal. And here are implants placements. Tapping is very important, not to break the bone, to prevent any shear forces on this thin bone. So augmentation is performed with bios saturating again in bone marrow or PRP, covered with BioGuide, both sides to close the window, and PPP on top of it. Multi-unit abutments were placed. Here I check the opening for the submandibular duct. Six months later, uncovering the implants that were buried, and rehabilitation is performed. So we started this way, and this is just prior to final rehabilitation. This is with a temporary, yet we haven't performed the final. I would like now to go a little bit about our experience with combination of BIOS with PRP and BioGuide with PPP for bone regeneration in non-infected versus infected dental extraction site. This research were performed in a support by Geistlich Parma, and we have already the result, not yet published. So the aim of this research was to evaluate the new bone formation in infected sites following guided bone regeneration. Those two cases that I showed you are part of this research. Perform at time of infection, infected teeth extraction or implants removal, using a combination treatment protocol, as we saw, biosaturated in PRP platelets-rich plasma covered with BioGuide, which was saturated in platelets-poor plasma, as we can see here in a different case of removal implants that we will see later on. This was a defect for this case. What was the timeline? 6 months after the removal of the implants or extraction of teeth and performing the GBR, guided bone regeneration, bone sample was taken and implants were placed for histological analysis. And we have several parameters that we examined in the histological, but I'm not going to go over all the research, just to give you some small details, just to have an understanding. What would be the difference between uninfected control sites with GBR, regular GBR in non-infected sites, and infected sites, still this extreme case of acute infected site. So we examined, for instance, the area of osteocyte percent and area occupied by different tissues, such as the fibrous tissue, new bone formation, and remnant of the BIOS. This is the few samples from non-infected site. I'm not going into it. You will have everything in the research that will be published. And this is, you can see, like it's similar for the infected site. And this, for instance, done from a free end area of the mandible after augmentation. So if we compare the non-infected site and the infected site and the new bone formation, one can see here in this large magnification that there is no difference, real difference between these two slides. If you look at these two graphs on the non-infected versus infected side, those are the different tissues on the left side of the screen that we examine. For instance, the osteocyte mean area, woven bone, soft tissue, and biomaterial, remnants of biomaterial. And one can see here that there is no difference between the non-infected and infected sites. And this is very important. This is very important since we can perform augmentation procedure in infected sites with no different histologically than infected site. So this is a very good answer and very good result for us, this no difference. Nevertheless, we got some difference in the amount of vascularization in infected site. And this is also a good sign because we like this vascularization, but this need to be we need more research on this result. The conclusion of this research was minimal differences comparing non-infected and infected site. Histomorphometry showed no difference in bone parameters. Vascularization was a little bit higher, as we saw in the previous slide, in infected site, and minimal difference between clinical features, sex, type of lesion, anatomical location, type of edentulosum were found. And everything you will find when this result will be published. I hope soon. I would like to go to the second surgical option to recover severe atrophy of the posterior mandible for implants placement. And this is autologous onlay bone grafting, vertical and horizontal. I have published many publications on different augmentations procedure, but if you look at the PubMed, only on onlay bone grafting, you can find 12 publications, and you can find the material and method for the techniques that I used for onlay bone grafting with autologous bone graft, intraoral autologous bone graft. I just want to go over one publication, this is 10 years ago, on the long-term follow-up of dental implants placed in autologous bone graft. And when we look at the total bone graft success, we have 96%. Nevertheless, when we examine the results for the posterior mandible, we get a little bit less bone graft success since we are dealing mostly with vertical augmentation, which is more challenging. Yet if we examine the implants' cumulative survival rate, the implants placed in those autologous bone graft in those areas, and this is 5 to 7 years cumulative survival rate of implants placed in onlay bone graft, we get quite a high number, and this is actually 10 years ago. So we are now conducting the new research on the next 10 years. So I hope for better results. So let's see the first case of autologous onlay bone grafting. So this lady, if you look at the posterior edentulous area on the right side, one can assume that we have enough bone to place implants as it is. Nevertheless, if we examine the CT slice, you can see here that the direction of the bone is toward the lingual. So the position of the implants will be quite difficult if we want to position implants in a way that will be opposing the maxillary teeth. We can perform here GBR as well. Horizontal augmentation is actually can be done in different techniques, yet I found that the onlay bone grafting from a neighboring area using autologous bone is very predictable and long-term success. So for that lady, I harvest the bone marrow from the posterior iliac crest, and after preparing the recipient site, harvesting of the monoblock autologous bone, I never perform inferior osteotomy to prevent any damage to the mandibular canal. And then I fix it with 1.5 diameter self-tap screw. And then after releasing incision of the periosteum, layer suturing. We are conducting also courses, masterclass for these techniques, how to perform vertical and horizontal bone grafting with autologous bone graft from a neighboring area. So this suturing technique is very important for the success of this technique. And I teach it also in those master classes. Here we can see just prior to separation. As I told you, I do only these 3 osteotomies, never inferior, and then I break it with a small chisel. And this is 6 months after operation, and you can see here that the difference in the width of the bone. So we had quite nice lengths here, but still we needed change not only in the volume of bone, but also in the direction, in the trajectory of the bone. And now we can place implants in a proper, favorable trajectory. So implants are placed 6 months after bone grafting. Screws are taken out. One can see here the incorporation of the grafted part. Implants are placed. 3 implants were planned, and then I used this opportunity for soft tissue manipulation as well. So in this case, I perform gingival graft, as you can see here. This is a planning, and this is immediately after operation, and uncovering 6 months later. I use narrow healing abutment to prevent any pressure. Look here on these two slides. Here is the area of the incorporation of the bone graft to the bone, to the native bone, and here after implants placement. And at 6 months and 4 years later, stable bone. I would like to show this article written, published in 2016 on vertical bone augmentation with autologous block or a particle in combination with guided bone regeneration. So this is very important to compare the blocks to the GBR for vertical augmentation. So this was performed in the group of Massimo Simeon in Italy. So they gain about 5 millimeter height with both techniques. Nevertheless, if we examine the histological results comparing the autologous onlay bone grafts and the GBR, that were both looks like a bone to implant contact were much better, and this is statistically a difference, favoring the autologous bone graft, and the same for bone field values. So they concluded that bone techniques were clinically successful, both techniques, for implants placement. Nevertheless, the histological showed that we have better result in autologous bone graft and also from vascularization and bone to implant contact. And this is very important. This is human comparison study. So let's examine another case of onlay bone graft. So all the time I used the time of extraction and implants removal for the first layer of augmentation. Even if I will perform augmentation later, like you saw the previous case of the acute infection augmentation and later on onlay bone graft, the same will be performed here. So implants need to be removed here, and you can see the intraoral view as well. And this is the gap after the removal of these 3 implants or removal and the affected tissue. And bone grafting was performed the same with biosaturated in PRP, covered with PPP and BioGuide, the same as we saw. And this is the pre and post-op augmentation. Again, one can think here that implants can be placed. Nevertheless, when we have a patient that already lost implants, I prefer to perform more augmentation, and it's not sufficient to just get a very thin layer of bone vertically. So for that lady, I also performed onlay bone graft, this time vertical onlay bone graft. Let's see the operation. So mid-crestal incision was performed, mucoperiosteal flap was elevated, and bone was harvested from the posterior mandibular area on the same side, the neighboring side. Bone was prepared for fixation with 3 1.5 diameter self-tapped titanium screw on top of a scaffold biosaturated in PRP and covered with PPP. And after releasing incision of the periosteum, closure with multi-layer technique. So this is a time of operation, and this sample was taken just prior to onlay bone grafting. And this is actually the 6 months after the augmentation procedure performed at time of implants removal. Here we can see remnant of the bios and the new bone formation. So we get this histological picture each time that we have augmentation at area of infection the same as in non-infected site. So 6 months after onlay bone graft, this is actually the second layer because the first layer was performed at time of implants removal. One can see here the amount of bone we managed to gain through these two procedures. And actually we get quite a lot of bone vertically at the area of the bone resorption and the loss of bone. And now implants can be placed very easily and safely. So the screws are taken out and implants are placed according to the pre-digital planning. I extracted also the wisdom tooth, used this opportunity to place membrane and some more augmentation material just in case. And this is the result immediately after implants placement and then uncovering and rehabilitation. If we examine the amount of bone that we can gain vertically through this procedure, we published it like 20 years ago. We gained also, like the group of Massimo Simon, we found out about 5.6 millimeter vertical augmentation. Nevertheless, sometimes we have defects much bigger than 5 millimeter. So what would be the surgical solution in those cases when we lost more than 5 millimeter of bone? We need more than 5 millimeter of bone for implants placement. So even ultra short implants cannot be placed in this amount of bone if we don't have a bone to begin with. So I present the multi-tier technique, intraoral vertical onlay bone grafting, many years ago. And I would like to share with you this technique. Moreover, I published another technique on the revisited donor side. So the last case of onlay bone graft that I would like to show you, the third case, is the use of multi-tier technique for vertical bone augmentation with the reuse of the donor site. So this 50 years old male was referred to my clinic with this situation, a remnant of the wisdom tooth on the right side and a failed implant on the area of the second premolar. So after extraction, you can see the amount of bone that we have here superior to the canal, almost no bone. And if you look here, this is actually the opening of the mental foramen. So this is the first operation performed, augmentation procedure at time of extraction of the tooth and failed implant that was done with trifine drill, preparation of the recipient site, harvesting monocortical bone according to the amount needed, vertical augmentation on top of scaffold of biosaturated in BMA, releasing incision, very careful releasing incision of periosteum, covering with PPP and layer suturing. So this is the technique that I use for onlay bone grafting, either vertical or horizontal or both. So this is the preoperative panoramic view comparing to after this first tier performed. If you look at this arrow, this represents the amount of bone still missing to get to the level of the neighboring area where we have the neighboring tooth. So again, we gain about 5 to 6 millimeter of bone if you look here, yet we cannot place implants here to hold the proper prosthesis. So again, the same technique was performed, harvesting bone marrow. And look here, when I open it, reopen it after 6 months, look at the area of the donor site. So this is reuse of the same donor site, placing bioos with PRP or bone marrow in the defect revealed new bone formation, as I showed you, in infected or non-infected sites. So the donor site actually is non-infected site. and I'll show you the amount of new bone formation at this area. So I used this bone again from this short place at the neighboring area. I could harvest bone twice, or even if we want, we can still go on and harvest bone, but we have to fill the defect at time of operation with bios saturated either in PRP or bone marrow and cover with PPP. So we need this blood product to help us with the healing of the bone defect. And here you can see the little part that I took at time of augmentation from this area of the donor site, and one can see here, this is a sample and magnification of the same sample, the amount of new bone formation around the remnant of the bios placed 6 months earlier. I named it the biobone block. So this is how we started, and this is after the second year. And now implants can be placed. Let's examine the pre-op slices of the CT compared to the slices after the second tier, 6 months after the second tier. One can see here the original border of the bone, first tier and second tier. Again, this is the original bone, first tier and second tier. So as a whole, this is the original bone and the amount of bone gained through these two procedures. Implants are placed 6 months later, so it means already 1 year after the first operation. Again, I take always a sample. Implants are placed. I used this technique for soft tissue manipulation, releasing incision, and covering the area, and closure with layer suturing. So we can see here the pre-op and situation after implants placement. Uncovery and implants rehabilitation after rehabilitation 2 years later and 6 years later. The third technique, and the last for this presentation, to overcome the challenge of severe atrophy of posterior mandible is the inferior alveolar nerve lateralization or transposition. What is the difference between transposition and lateralization? Actually, the difference lies in the mental foramen. We either separate it and cut the incisive branch. We don't cut the mental nerve. One has to know we don't lose by this technique the sensation of the lip and chin, but only the incisive branch. Nevertheless, the lateralization, we prefer the lateralization, not interfering with the incisive branch. So those are the difference between, and you can see here in this slide, the differences between lateralization and transposition of the inferior alveolar nerve. Let's examine this case. For this lady, the prosthodontist decided that teeth would be extracted. So we are left actually with a dentulous situation, so augmentation of the posterior area is not recommended. Here you can see the panoramic view of the CT, and one can appreciate the amount of bone loss at the area of posterior mandible and the close relation to the position of the canal both sides, on the right and on the left. When we would like to plan the position of the implants in advance and we have still teeth to be extracted, and also we would like to perform immediate provisionalization, we need to prepare two surgical templates. One prior to extraction and the second after extraction. And it has to be exactly on the same place. So the position of the fixation screw is in the same place. So let's see this case. First, this is the first template just to perform the position of the fixation screws and the amount of bone removed at the area of the teeth that extracted. And here we can see just prior to implants placement. And this is the second template, so the same position for the fixation screw, and these are the position of the planned implants. At the operation, extraction of the remaining teeth, mid-crestal incision for mucoperiosteal flap, and this is the first template for the amount of bone to be removed, and here you can see with the piezo, and this is already the second template for marking the position of the implants. Window is taken like we saw in the previous case of lateralization of the mandibular canal, careful dissection of the canal, neurovascular bundle, both sides. On the left side, we plan for transposition since the position of the planned implant was exactly at the area of the incisive canal. Nevertheless, this separation is done just at time of implant's placement, and you can see here after the separation of the incisive branch, holding with vessel and nerve loop very carefully the bundle, neurovascular bundle, placing bios saturated in PRP covered with PPP, and tapping is performed to prevent any shear forces on the thin bone that was left there. Multi-unit abutment was adjusted for immediate loading, and this was done by the prosthodontist. And this panoramic view was performed after the final prosthesis was performed. I would like to conclude this lecture on surgical solution for reconstruction of partial edentulous posterior severe ridge atrophy using Geistlich materials such as BIOS and BioGuide. And you have to remember that I used also blood product, PRP and PPP, or bone marrow aspirating. One can use also PRF. We have many cases with PRF. Nevertheless, I was talking about three important techniques: guided bone regeneration in infected sites, autologous horizontal and vertical onlay bone grafting for implants placement, and I introduced the multi-tier technique and the reuse of the same donor site. And the last technique that I showed, actually I showed it twice, at the beginning, at the end, mandibular nerve lateralization and transposition. With this, I would like to thank you for your attention. Thank you very much.